Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Thank you for tuning in to Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. I am your host, Joel Berg. And thank you to our Pedo Teeth Talk sponsor, Hugh Freedy, for helping us bring you great content. We couldn't do this without them. Visit them at www.hughfreedy.com. That's HU-FRIEDY.com. We're here today with Dr. Stephen Wilson. Dr. Wilson is currently the Chief Dental Officer of Blue Cloud Pediatric Surgery Centers, PSC, a corporation with multi-state ambulatory surgery care holdings, and is a consultant in the profession of pediatric dentistry, specifically in the field of child sedation for dental procedures. He also is adjunct professor in the Division of Pediatric Dentistry at Nationwide Children's Hospital, consulting on sedation practice in the Advanced Pediatric Dentistry Training Program. He teaches sedation periodically at UNLV School of Dentistry in the Advanced Pediatric Dentistry Program and has served as a faculty member, speaker, and consultant to the Institute for Pediatric Dentistry. So, Steve, thanks for being with us today. And as a way of intro, amongst your many talents, I just want to ask you, since you're the guru on sedation education, we all know that, how many sedation courses have you given in your lifetime?
Joel, that would be a very difficult question to think about. I'd have to go back and look, but probably somewhere in the neighborhood of 75 to 100 courses. I would imagine, certainly over the last 20 years, I've been involved with the American Academy of Pediatric Dentistry's sedation course almost since its beginning.
Well, I think our members would say 1,000, but we'll take 75. I think now that we've established you as our expert witness here, so to speak, I wanted to ask you some actual questions about sedation. This is a topic that's so important to all of us. So you've been involved with the development and the writing of sedation guidelines for the Academy of Pediatrics, together with AAPD, as well as the American Dental Association for many years. We've had some changes, some significant changes recently, but over the years, what changes have you seen in the sedation guidelines?
Well, Joel, first of all, let me thank you again for having me on the podcast. There's definitely been some changes over the years with our guidelines. These changes reflect issues like definition changes. For instance, we'll remember that we used to refer to the definition of quote, conscious sedation, unquote, which has now been broken down into minimal and moderate sedation. There's other issues that have arisen, monitoring equipment and the hierarchy of monitoring, as well as practitioner training and rescue skills. So those major changes have occurred over the last few years. I feel that there's been a consistent thread throughout the years with our guidelines, though, in that they have emphasized protocol and office readiness to aid in the safety of sedating children. And certainly one of the biggest changes that has occurred in the last rendition of our Academy's guidelines is the requiring of a third independent practitioner being present whenever deep sedation or general anesthesia is administered. And this third person, according to our guidelines now, must be an anesthesia-trained individual and not someone like an extra dental assistant.
So not a dentist necessarily, but you're saying like an assistant, perhaps, who has additional training in anesthesia specifically. That's what.
Yes, specifically, it could be a dentist, such as a dentist anesthesiologist or an oral surgeon who is very familiar with sedating young children.
I see. So given these changes in the sedation guidelines, and by the way, when I say sedation guidelines for the purpose of our conversation today, we're referring to the combined AAP, APD guidelines, just so our audience knows what I'm referring to. So state boards ultimately control what happens on a state-by-state basis by virtue of their Dental Practice Act in each state, should they consider our guidelines? Are they already doing that in terms of what they enact for their various state practice acts?
Well, it would be nice if the joint guidelines were a part of every state's Dental Practice Act. I think as we speak, there are only 11 states that have our guidelines and their regulations, and we're certainly grateful for that number. When one thinks of state practice acts related to sedation, we tend to think of the different types of permits that are out there, office inspection requirements, and CE requirements. But it's our guidelines that make a very nice protocol to follow. They lay out training and clinical requirements needed to safely treat children, in my opinion. And the guidelines are really exhaustive in terms of references and supportive literature. So, in my opinion, again, therein lies the great benefit of the guidelines for state regulation and the practice of sedation.
So for the states that do not currently use our guidelines, I guess the other 39 states, would they have other guidelines they use, or they just don't refer to any actual guidelines from an entity?
I don't believe that they refer to any other guidelines. There may be some exceptions, Joel, such as the ADA guidelines on the teaching of pain control and sedation. But my memory doesn't serve me specifically on whether that occurs or not. But at least we have 11 states that have included us.
And I suspect growing. So regarding changes in guidelines, are there any you foresee occurring in the immediate future? Are there some on the agenda?
Well, it's always difficult to predict the future. I think the future changes in guidelines, they're going to occur, and they will likely mirror new information in the field of sedation and general anesthesia. You know, as new technologies arise, especially in areas like patient monitoring, and as databases highlight errors and key factors associated with adverse events, we'll see changes in guidelines. Currently, we don't have any significant sedation database in dentistry, especially for pediatric dentistry, but our medical colleagues do have such databases with very large numbers of patients and a host of factors that they consider. And I think information from those resources will help in guiding future changes in our guidelines. I just want to mention that I think the field of sedation study is really going to be fun and interesting in the future. For instance, I truly believe, and I hope this happens soon, that we have a monitor that detects both physiological and behavior measures simultaneously. And they'll have built-in algorithms, at least in my mind, that will mimic the simulation that is an integral part of the commercial aviation safety. So right. I think there's going to be a lot of interesting things in the future that will impact our guidelines.
Well, speaking of guidelines and monitoring, you mentioned, I wanted to cover that right now. And that's, you know, if you think a few years back, and I'm old enough to remember that when we didn't have various monitors like pulse oximetry, where you actually had to look to see if the patient was turning blue, the color of their skin. So what was the first monitor you started using with sedations? And let's then ask what you recommend today for people. What's the state of the art for monitoring? But what did you first start with way back?
Well, going way back, you're right. The only monitor that I had when first doing sedations, other than myself, was an automated blood pressure machine. I think it was a Pretracheal machine. I'm not sure about that. And the drugs that we were using back there, or the main drug, was a drug called alpha-protein or Nicental, which, in my opinion, was one of the best sedatives we ever had. But
I agree with you. That was a great agent. Yeah.
Yeah. But its margin of safety was very narrow, and due to some significant number of deaths, it was removed from the market. But in today's world, the pediatric dentist has an array of monitors to choose from as they become affordable, integrated and well automated. And so the dentist just has to decide on the levels of sedation at which they're most comfortable in doing sedations. So for minimal sedations, a pulse oximeter is likely all they may need, maybe a pretracheal stethoscope to go along with the pulse oximeter. But if you're doing any deeper levels of sedation, I'd recommend an integrated monitor that contains oximetry, capnography, blood pressure, and maybe even EKG, because who knows if the EKG will be a part of regulations in the future. And I still like the pretracheal stethoscope for deeper levels of sedation to complement that integrated monitor.
But you don't think for minimal sedation, the precordial stethoscope, pretracheal, is required in most instances, if that's all we're going to do?
Well, if it's just something very minimal like nitrous oxide, I don't believe that we even need a pulse oximeter. Probably just clinically monitoring of the child is fine. Although, as you know, the federal services do require a pulse oximeter even with just nitrous alone.
Right. Yeah, it's kind of migrating in that direction. So you mentioned capnography, and I know there's been some debate over the last years about, do I have to have one? You mentioned the integrated system with the pulse oximetry and everything all together, like you have in an operating room for an anesthesiologist. What is the state of affairs on capnography? And, should we have one? Do we have to have one? Are there state-specific rules? What's the story today?
Well, I believe that capnographs certainly are becoming close to the gold standard along with pulse oximeters. There's children out there that I refer to as the third standard deviation child who are very hypersensitive to an agent, even a low dose of a single agent, or when you combine that with nitrous oxide. So they get deep very, very quickly. So you need a monitor that will help you understand where they are in terms of their airway. And the capnograph for children who become deeply sedated or even moderately deeply sedated is an excellent monitor to have. So I think absolutely, yes, the practitioner who's doing those deeper levels needs the capnograph for keeping the child safe and understanding where they are in terms of what to do.
And the price was an issue before, as price has come down a lot for those. Is that correct?
The price has come down, yes. I remember the first capnograph, talking about capnographs of a long time ago. The first capnograph I bought was a Datex back in probably 1990, and that cost me $10,000 just for the capnograph. But today you can buy an integrated unit for $1,000 to $2,000.
Yeah, that's very reasonable compared to the past. I had a couple of patients in my former practice whose father was the chief paramedic in the area, and I did some ride-alongs, and I watched CPRs done by these paramedics beautifully. And to them, the capnograph is the most important device to monitor ventilation. So I'm thinking if that's what they say in that experience, then just in terms of monitoring adequate ventilation, you can see how important the capnograph is. I don't know if that's a fair analogy, but it seemed appropriate to me.
It is. Reading capnograph waveforms is a lot like reading EKGs. If you observe the patient's physical breathing efforts and you're watching the capnograph waveform, you learn very quickly what's a false positive, and you shouldn't have to respond to that. When the airway is fully blocked or mostly blocked, such as in a laryngospasm situation, when you have a partial blocked airway, and that requires you to do something simple like just a head tilt jaw thrust maneuver, which reopens the airway. So the capnograph is an excellent tool, and I should say so is the pretracheal stethoscope. It's good for those types of situations as well.
Yes. We will now pause for a word from our sponsor.
Hugh Freedy is the global leader in dental instrument manufacturing, offering pediatric restorative solutions that keep you performing at your best. For more information on Hugh Freedy products, visit www.hughfreedy.com/AAPD crowns.
We're back with Dr. Steve Wilson. We're talking about sedation, and we've got the expert right here. So, Steve, I want to ask you about regimens, get right into sedation regimens. We hear a lot about different regimens in different offices. So what factors do you consider or recommend to us when you're selecting a regimen for a child? How should we decide this child is here today? What am I going to use for them to sedate them?
Well, Joel, I think there are two major or dominant factors that need to be considered. One is child temperament and personality, and the other is the amount of dentistry that you need to do with a sedation appointment. Evidence strongly suggests that a very shy, almost frankly inhibited child do very poorly under minimal and moderate levels of sedation. They actually require deep sedation or general anesthesia. And children who tend to be hyperactive and or have poor emotional control and lack a reasonable set of coping skills, they're going to need deeper levels of sedations as well. The other major factor that we have to consider, as I mentioned, is the amount of dentistry that you need to accomplish. If you have a lot of dentistry to accomplish, or if other factors come into play, for instance, a long distance that the patient and family have to travel for care, then sedating a fairly cooperative child, in my opinion, is not necessarily a bad clinical care. Then there's children that have troublesome dispositions and are slightly afraid, but you only have one or two teeth to treat. And if you feel comfortable in doing a light sedation and maybe even passive immobilization, as long as the parent consents, I think that's good. But if the child is very fearful, frankly inhibited by social interactions and uncooperative for simple things like a prophylaxis with a handpiece, I don't have a problem with using deep sedation or general anesthesia with an anesthesia-trained professional by my side. Let's face it, our ENT colleagues do this all the time just for 2 ears.
Right.
So our problem
that's a lot easier than what we do, by the way. Putting tubes in those ears than doing an MO on a little moving target is much more difficult for us.
Absolutely. All we have to do is figure out how to introduce the appropriate type of legislation to maybe force that compensation issue with third-party payers to pay for those children.
So talking about drugs, can you comment specifically on the common sedative drugs that you are aware that people are using in their offices, a little bit about each of them briefly?
Yes. The major, most pervasive sedative agent that's being used today is midazolam, and the benzodiazepines are very, very popular. Occasionally, I'm surprised by what my colleagues tell me about their sedation regimens at our academy's sedation course. Old recipes like thorazine and hydroxyzine, they're still out there. Some are using oral ketamine and morphine, that sort of thing, and that's a bit scary. But what scares me the most is hearing of individuals who give boluses of drugs without regard to the patient's weight. In other words, they may have had compounded drugs done for them by a pharmacist, and they give a teaspoon or two to a child without knowing the milligram per kilogram basis. And that's really a protocol that's not even supported by our guidelines. But let me just talk very briefly about several regimens that I think most of us use in our practices and that we see in our publications. And those are regimens that include meperidine or Demerol with the antihistamines such as chlorohydrate. There's also a lot of folks using the benzodiazepines with meperidine. And you'd be surprised, but a lot of folks also tell me that they're using the triple combinations where they use meperidine, hydroxyzine, and midazolam. And,
so you mentioned chlorohydrate. You meant hydroxyzine as the antihistamine. Is that right?
Oh, did I say chlorohydrate? I'm sorry. Yes.
Just to be clear, you meant hydroxyzine. Is that correct? Yeah.
That's what I meant. Yeah. I would say that one of my favorite triple combinations does involve chlorohydrate, but it's a very low dose, like 10 to 20 milligrams per kilogram. And then you can use meperidine at 1 to 2 milligrams per kilogram, and then hydroxyzine at a half. I think there's still a lot of folks using that particular regimen, even though chlorohydrates has to be compounded.
So just in general, in terms of benzodiazepine, versus adding a narcotic, just sort of categorically, in what situations would you say, or is that even a fair question to ask? Just Versed alone or Versed with Demerol. Are there differences in circumstances, or that philosophical, or how would you characterize that?
Well, it depends upon the practitioner's training, actually. If the practitioner only learned with just a benzodiazepine, such as midazolam, then they may use that for every type of procedure, whereas I feel like for incidences involving trauma to teeth, benzodiazepine to help with memory and or I should say amnesia, I think that's a very good drug. When you're considering wanting to do a little more dentistry, remember I talked about the amount of dentistry that needs to be accomplished. So if you add two drugs together, like a benzodiazepine and a narcotic like meperidine, then you're going to get a longer working time. So I think putting agents together and adding a little analgesic, or maybe even helping with amnesia, is a good combination to consider.
Okay, so the training, though, I think that what I'm hearing you say is, based on how you trained, is one of the most important things, because you understand how to manage with that regimen, and that's really the key point I'm hearing you say.
Yes. Let me just talk about, just briefly, the current sedation training in our advanced programs. I personally feel like there's two issues with our programs today. One is the lack of faculty, and the other has to do with sedation research. I think not having, or having only one or two members of the faculty who have broad experiences in various levels of sedations, understand combinations of agents and when they're appropriate for different types of children or procedures, knowing monitors and their applications, and having extra training in airway management. I think that's really great, but I've heard where programs may have newly graduated faculty members who's doing the sedation teaching, and I think that's unfortunate. And how do we change that situation? That's a great question. I think one of the answers is to send faculty members to a training program that has well-qualified teachers. And there's a few of those programs that are out there. The big problem, however, is logistics. How do you pay for the housing, compensation, and issues such as regulatory issues with the licensure?
Right.
So those
could be solved, I think. If we were determined, I think those are solvable problems.
They are solvable problems. And I think another big issue is sedation, with regards to sedation training, is the lack of a good research in that area. We really need to have a comprehensive overhaul of sedation research. We need comprehensive drug dose studies. We need to look at key factors of personality and temperament, and how you instill coping strategies and in youngsters and how the different drugs affect those. But Joel,
seems like we had a lot of studies 20 years ago, but now it's kind of like a lull right now in studies at the moment.
It is. And in fact, I really feel like we even need more comprehensive non-pharmacological behavior guidance research. And I think a way to do that, because the programs are the obvious groups that can do this, but I think what we ought to do is consider linking up programs and their faculty with good practitioners that are out there all the time doing sedation to find good ways to do systematic studies. And I think that can be done with our technology today, communication technology, and so on and so forth. Because if you look at the number of sedation studies that have been published within the last decade, as you mentioned, not only are there fewer studies, but most of those studies are now being done in foreign countries like South America and India. And that's fine, but I think we need to refocus our research in sedation and behavior guidance here in the U.S.
Yes, makes a lot of sense. So we just have time for another question. There's something we covered so much, but I want to get in the issue of continuing education and safety to combine those issues. That safety is obviously a lot of what we're talking about in correctly performing these sedation procedures. So what would you recommend to us in terms of what pediatric dentists can do to ensure they're doing safe and effective sedation, and specifically in terms of education, continuing education for them and maintaining their skills?
Well, one recommendation I would have is for those people that are doing a lot of sedations in their practice is to keep up their skills in airway management and emergency management. One way you can do that, keep up those skills, is to work on a regular basis with our dentist or medical anesthesia colleagues. And for me, that meant quarterly I would ask my anesthesia colleague if I could start the IV, if I could insert an LMA, if I could do the intubation, and I just kept up that skill over the years. If you learn that skill 20 or 25 years ago and you never used it again, you're going to quickly forget.
Definitely.
Another really great way of maintaining your skills is through the use of human simulation. And I know that can be costly to take those courses every year or two, but you really learn how to work in teams and how to manage emergencies. And simulation teaches you and your team how to prepare for and set up for sedation and its complications, how to recognize adverse events, and to work as a team in patient rescue algorithms. And most importantly, it could save a child's life. So I think human simulation, attending CE courses on a regular basis, practicing emergencies with your staff on a quarterly basis, and considering bringing a consultant to your office to review your sedation protocol, policies, and emergency readiness. And I certainly would be happy to offer that particular consulting service to my colleagues out there if they're interested.
You heard that right here on Pedo Teeth Talk, folks. It reminds me of what you said earlier, Steve, about aviation. There's so much analogy to the aviation industry with pilot training. And for us doing sedation, you're dealing with emergencies that you hope will never occur, but you need to be prepared in each instance that they might occur. And yes. I think that's what you're saying to us. So it's, wow, what a wonderful chat I had with you today. I learned a lot, and I know our audience did, and they're going to want more. But we do offer a lot of courses through the APD, and you're always willing to reach out. And I really appreciate talking to us today on Pedo Teeth Talk. So thank you to you very much, and we look forward to reconnecting.
Thanks, Joel. I really appreciate your asking me and having me on the podcast, and thank you very much, and have a good day.
And thank you to our audience for tuning into Pedo Teeth Talk, where we bring you the contemporary issues important to you in your practice, brought to you by the American Academy of Pediatric Dentistry. We'll see you here next time.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.